Hi, good afternoon, everyone. It's great to have so many of you joining us today. For those of you who may be new to these calls and don't know me, I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health and a member of the Thrive Kentucky campaign. I know most of you are familiar with Thrive Kentucky by now, but for those of you who may be joining us for the first time, we can go to the next slide, Alex or Kelly. These are the principles, the guiding principles that we use to help us focus on the policies that Kentuckians need to thrive. And you'll get this slide deck, which is relatively short, as a follow-up to this, so you don't have to feel like you need to read everything on the slides, but we just like to share this information up front so that you understand a little bit more about the focus of our work. We can go to the next slide. Here are the members of our Thrive Kentucky campaign. And if you want to learn any more about any of our organizations, you can click on these links. We go to the next slide. We always like to say thank you to our sponsors who make this work possible. We are able to provide these, our monthly webinars and our quarterly forums with the Cabinet for Health and Family Services for free, and to also bring to you in-person roadshow events that we do about 8 or 9 months out of the year, and we'll be kicking off right after the legislative session ends. So we really appreciate the support, and we're just getting started with our sponsors this year. We recently sent out information about sponsorships to a number of organizations. It's in our newsletter. If you're interested and you want more information, please reach out to Kelly and she can put her email address in the chat. Why don't we go to the next slide? All right, here's more information about some of those other webinars and the roadshow schedule that I just mentioned, and we'll have a flyer out for you soon. We can go to the next slide. And here's the agenda that we're going to be covering today. We'll have updates on the Kentucky General Assembly that's in process now, childcare, food assistance, Medicaid renewals, and new Medicaid covered services. Also, the Medicaid waivers that provide home and community-based supports to people with disabilities, as well as some new waivers that are in development now that would provide additional supports to Kentuckians with serious mental illness, as well as those who are being released from incarceration and reentering their communities. And to discuss all of these topics with us today, we are really delighted to have on our call the Cabinet for Health and Family Services Secretary Eric Friedlander, as well as Deputy Secretary Carrie Banahan, Medicaid Commissioner Lisa Lee, Medicaid Senior Deputy Commissioner Veronica Judy Cecil, Medicaid Deputy Commissioner Leslie Hoffman, Medicaid Behavioral Health Supervisor Angela Sparrow, Director for the Division of Long-Term Services and Supports Pam Smith, Director of the Division of Family Support Todd Trapp, Division of Child Care Director Andrea Day, Department for Public Health Deputy Commissioner Dr. Connie White, and Department of Aging and Independent Living Division Director Marnie Mountjoy. So we really appreciate that the Cabinet has taken the time to have so many of their leaders join us today, and to provide some access to additional information, opportunities to ask questions directly, connecting with advocates and with other stakeholders. And so with that, I just want to do a little bit of housekeeping. We, of course, have a lot of folks on the webinar, so please be sure to mute your line. We are recording this. As I said, we'll send out a link to the recording, to any materials that we share today, and an evaluation in a follow-up email. You can watch for that tomorrow. If you're a certified community health worker or a licensed social worker and you would like to receive CEUs for attending today's webinar, be sure to complete the evaluation that we send out in the follow-up email. We want everyone, of course, to complete that evaluation. We really appreciate your feedback, and it helps us to plan these webinars and make sure we get good content to you. But if you want CEUs, it's a requirement. And if you have questions or comments, please be sure to put those in the chat as we go along. We'll try to address as many as we can. And if we can't get to everything, we will make sure to address those in our follow-up email. So I'm going to turn it over to Dr. Sheila Schuster to kick us off with the General Assembly update.
Thank you very much, and good afternoon. I'm Sheila Schuster. Is that the right slide? Yeah.
Well, and we had just discussed switching things around, and it already flew out of my mind. So we're going to start talking about waivers first. Sorry to confuse
That's
anyone.
right. The General Assembly is still going on, and they will still be going on after we talk about waivers. So I have a couple of questions for Pam Smith, who is the at Medicaid as the Director of Long-Term Services and Supports. The first, Pam, is what are the current waiting list numbers for each of the home and community-based waivers, particularly Michelle P, SCI, SCL, and the ABI waivers?
So am I, sorry, am I able to share my screen?
I think we can make that happen. I'm sorry, Alex, I should have told you that.
That is okay.
Slides.
I think you should be able to share now.
Okay. I will. Let's see if I can figure out. Okay, looking at what screen, trying to make sure I've got it on the right screen. Okay, let's see. So I have just a couple high level slides talking about. So right now, we have 4 waivers that have a wait list. ABI long-term care, the HCB waiver, Michelle P waiver, and SCL. So of course our ABI waiver serves our individuals with brain injuries. And this is the long-term care waiver, which is focused more on long-term community supports versus acute rehab. Home and community-based waiver, which, as you all know, is our longest standing one of our longer standing waivers and largest waivers that serves our aged and individuals with physical disabilities. And then both Michelle P and SCL that serve our individuals with intellectual disabilities and developmental disabilities. One thing to say is that individuals are placed on the waiting list by meeting waiver targeting criteria. So placement on a waiting list does not guarantee necessarily that they will be admitted to the waiver once they actually have a slot allocated to them. Once that happens, they have to be assessed, and they have to meet level of care, and they also have to qualify for Medicaid and a type of assistance that supports waiver services. So here's looking at the slots right now. We have, so you'll notice for ABI long-term care and HCB, you're going to see that there are 9 slots in ABI LTC and then 158 in HCB, and you'll see that asterisk. Part of that is because some of those slots, all 9 of the ABI LTC and a portion, 37 of those for HCB, are actually earmarked in our waiver applications for transitions from nursing facilities using our money follows the person dollars, and been very excited. We've been very busy this year, have already moved I believe over 4 people out of facilities beginning with the beginning of this year, and have a full pipeline coming in behind that. So we've been very busy, but that's why you see it's kind of confusing to see the available number. The other 2, as you get down to Michelle P and SCL, you'll notice I have added into the funded slots. We've added the 100 slots that we were given for fiscal years 23 and 24 into the Michelle P and SCL, into that number, that beginning number. We are just waiting on the final sign off from CMS. Those applications have been with that. Those approvals got tied up in part of the reviewing for the extensions of Appendix K and the rate changes. So we have not got that final approval from CMS, but we expect that to be coming very soon. So I've added those in there. You'll notice we have 401 available slots for Michelle P and 202 for SCL, whereas the wait list for Michelle P is now 8872, and for Michelle P and for SCL it's 3414. For SCL, we allocate on an emergency basis only. So anyone, if you're already on the SCL wait list at any point in time, you can file an emergency application. If you are not on the wait list yet, you can submit an emergency application from the start. And so we use those slots to make sure when we have kiddos that may be aging out of DCBS, that will be needing to go into those residential settings to make sure we have a spot for them, and that we have a spot for those individuals that have had something tragic or something happen where supports that were meeting their needs no longer are there or no longer able to do that. So that's why we reserve those spots. Michelle P, it's a little more interesting. We've been allocating slots in Michelle P about every 90 days since 2018. You will see we still haven't got up to our 10,000, even to 10,000. We're at 9964. I think at one point our highest amount served was about 10,200. We are allocating now in collaboration with BDID 75 slots a month for Michelle P, and have been doing that for some period of time. However, 50% of those slots go unused. And so what that means is either we cannot find the person, so we can't find them, the CMHC can't find them. There's no way for us to even locate them to get the information to them. So there's a big plug for reminding people to update their addresses with DCBS. But also they get the slot and they don't want it. They don't recognize why they signed up for it. They don't need it now. They're getting services on another waiver. Their needs are being met. So each time, we allocate 75, but 50% of those go right back in the same bucket, just to be allocated again because they're not being accessed. And something else that we added in that adds to the available slots is that, I don't know if you all had heard, but that prior to when an individual passed away during a waiver year, their slot was held until that waiver year restarted. Beginning the end of last year, we put changes in place so that waiver slot can be reallocated immediately in the cases that an individual that was using that slot has passed away. So that does give us a few more available slots as well.
And Pam, that's been since the end of last year, roughly?
It was the end of last year. It was,
Okay.
I'm trying to think, like last quarter, like October, November.
Yeah, that sounds right.
So
Okay,
a few
thank
other
you.
things I wanted to mention is that kind of how does somebody get on the wait list now, and why it means that an individual may not be going without services just because they're on a wait list. So they're applying for waiver in a no wrong door process, which means when that application comes into us, they're not saying, I want to be on Michelle P, and that's all they get looked at. They submit an application, and then we look at them and say, okay, you meet the targeting criteria for, Michelle P for SCL and maybe HCB. So they will get evaluated by every waiver that they could potentially be served in. The individuals can be waitlisted for more than one waiver at a time. They can also be waitlisted on one waiver and receive services in another waiver. And I'll show you some information on that in just a second. To apply for waiver services, so to even complete that waiver application, you have to do the Medicaid application from start to finish. So if you're someone who does not have Medicaid eligibility to start with, you have to start at the beginning and complete your Medicaid application. Now that application may pend and it may not complete, but you have to get so far into that before you can even get to the spot where you can apply for a waiver service. And that in the end really shortens the time frame when somebody does get a slot. It shortens the time frame for them being able to access benefits. But here's I think what is really interesting is that when we looked at our individuals that are on the wait list, and we looked at how many of them are Medicaid eligible, which would mean they have access to other state plan services. So they have access, for home health care. They have access for durable medical equipment. They have access to therapies. When we look at that, there are actually, let me get my percentages right, in total, 86% of the individuals that are on a wait list for a waiver, 86% of them have Medicaid eligibility and can be accessing services through other state plan programs. Another interesting thing I think to look at is that last column, the number that are waitlisted, but they're receiving services in another waiver. So of course, our one person in ABI that's waitlisted, that individual is currently receiving services in another waiver. Let me get my numbers here. I apologize. This is what happens when you have multiple screens and you're trying to get all the pieces up on the right spot. So for HCB, so 79% that are on the wait list also have Medicaid eligibility. Much smaller percent, it's only 1% that are receiving services in another waiver. That is most likely due to just the difference in population. Those individuals do not typically meet the target criteria for the other waivers. For Michelle P., 84% of the individuals on the wait list are Medicaid eligible. 26% are receiving services in another waiver. Another key point to think about with Michelle P. is that over 70% of the individuals on that wait list, so of that 8,872, 70% of them are children who likely also have access to third-party coverage through a parent or another caregiver. So we may not necessarily see exactly what other services they are getting. They also have access to some other school-based type services or other services they may be that you do not have to be Medicaid eligible to receive as a child. And for SCL, 93% of the individuals on that SCL wait list are Medicaid eligible, and 59% of those individuals are receiving services in the community in another waiver. So the wait list numbers look high. I think we all agree that the wait list numbers are high, but I think this also lets you look at it through another lens, that it doesn't mean that all of those individuals are just sitting and waiting and do not have access to other services to meet their needs, or do not have or are not receiving any type of services. So I'll pause there and ask if there's any questions.
No, I think people have been concerned about whether you're filling slots as they come available. And it sounds like that's true if the person leaves that waiver, either through their death, or if they leave a waiver for some other reason. Does that slot get filled right away, Pam?
It does not get filled right away. It does not get filled right away. And I will tell you the reason is because, and I don't have the percentage with me, but I could work on gathering that. Many times we give those slots back within that same waiver year. So a lot of times they may move and then they pop right back and they need services. And so we're able to, by keeping that waiver slot assigned to them until the end of that waiver year, it allows us to slide them right back into services without them having to go on the waiting list again. Another reason we will hold slots temporarily is if, for example, something happens, they break their leg and they, so typically you can be on hold for 60 days. So you can put your waiver services on hold for 60 days. But if you have a catastrophic accident and you get put in the hospital through no fault of your own, and we don't want you to lose your waiver slot and have to go back on into a wait list. So we will hold that spot, even if it's over those 60 days, so that you can come back into those services. Same thing with if there's eligibility disruptions. So there's been some confusion, although we've been working very closely with our team in eligibility about helping parents understand, in particular, when the age comes of when, it's looking like they need to make that SSI, the application, and have those done. But sometimes, those processes are not short and there may be a delay. So we want to make sure we have that slot for that person to come back into so that they can start getting their services again, because the disruption of services really were not, it was not their fault. I mean, there was something happened that was outside of their control. So we want them to be able to come back in and be getting those services again and not have to be waiting because we've just automatically filled the slot again.
Yeah, and I think in the chat we just saw, I think people understand or are glad to hear that there are Medicaid services available to people while they're on the wait list, but that's not the full range of services that they would get once they're in the waiver, right?
Right, there are different correct, there are different types of services that they could receive that are not available as a state plan. For residential, for example.
Right. Pam, we know that House Bill 6 allocated more new slots or placements for those waivers than we've ever seen before. Do you have those numbers available?
I do not, and what I will say,
Okay.
and I think that either Secretary Freelander or Deputy Secretary Banahan or perhaps Commissioner Lee might speak to this, that we really can't, we don't know what those numbers are going to look like and what that final is going to look like. So I don't know that I really can speak to that yet at this time till we know what, kind of our final budget is going to look like and what slots we will have.
Well, I think the secretary is going to join us here in just a second. Let me ask you one other question, because this just came up this morning. I heard from actually two different people about a number of involuntary terminations of individuals who were on HCB waivers. I think one number I saw was 67, another one was 73. And that is a concern. And I guess, can you tell us what the cause? I mean, obviously not the individual case, but generally what the causes for those involuntary terminations are?
I honestly would need some more details, Dr. Schuster. That concerns me. I want to understand a little bit more about it. So if you can connect me with who you're hearing it from so that I can look into that a little more closely to see what the cause of those were. Were they related to eligibility, or was it they were just involuntarily terminated out of the program? Do you know any other details?
I don't know any other details. As I said, I paid attention particularly because I knew we were having this webinar and that you were going to be on. So let me get back to you offline, and maybe we can present it the next time we have this joint webinar with the cabinet and Thrive, and come back to that, because that issue has come up. Obviously people are concerned if somebody's been involuntarily terminated from and I'm sure that the reasons get distorted perhaps in the retelling. So let me get some facts for you and get back with you. I appreciate it.
Thank you. Yes, and I will look into that.
Okay, great. I understand that Secretary Freelander has made his way, I guess, back from another area of Frankfurt. So welcome, Secretary.
Sorry.
Yeah. I can hardly see you.
Technology
Okay.
sensors.
You look real, oh, there you are. Great. All right.
How's that?
That's great. And Deputy Secretary Banahan is there too. Welcome. We're very glad to have you join us. We have some questions. I wanted to start with this is a budget session, and so I wanted to start with House Bill 6 and just ask generally how you and the other folks at the cabinet are feeling about the budget at this point in time.
Quite nervous. I will be testifying on Wednesday, Senate A&R. So the nervousness comes from this. Areas that are of concern are really kind of what you just talked about, but more generally Medicaid. Feel like there's been some I'm worried that when you underfund Medicaid, particularly in the growth side of it, which is what it appears to me that this budget does, and many of you were on a call with Governor Beshear about the budget, and what he said really applies, which is very nervous about Medicaid. looks like underfunded, or fund switches, that meaning moving from general fund, which is, you know, the tax money, to agency funds, which is money an agency actually earns. Really looks like it's going to be tough for us in 25. So I am nervous about that, and some of the pieces that are there perhaps not being fully funded with general funds. So that makes me quite nervous. The first version of the House budget had the mobile crisis piece in it. The second version did not, which is heartbreaking for me, because I think it's really important in how we respond in local communities to folks who are in some behavioral health or substance use crisis. And when we were going around the state with, and again, many of you probably came to some of the AOC, Administrative Office of the Courts, and behavioral health. Every place we went, it was really this part of the first where you meet somebody really on the street, this part of the system that is truly broken or has incredible challenges, and that's one of the ways we were hoping to address it, even though it's a long rollout, as you all know. So nervous about that, nervous about some of the funding in behavioral health, particularly around some of the personnel pieces. I'm concerned about that. The governor's budget had AOT, the House budget doesn't. So there just, you know, there's some concerns with that as well. And then there's some personnel pieces again in behavioral health, because we really, most of our facilities are done through contracts and contracted personnel. We left the personnel complement on the books in case we ever had to switch back. But, you know, when you take those vacancies, it's actually a hit to our facilities. So I'm nervous about that. And then let's see what other cheery things I have relative to budget. There's a little bit of less personnel in the Secretary's office, which really wouldn't bother me at any other time, except the Inspector General's office is in the Secretary's office, and we need more folks there, not less. So again, it's not a big dollar figure, but it's disconcerting because we are so understaffed in the Inspector General's office. So again, just hear my nervousness. This is the start of the budget. It will go through the Senate. So just, you know, if there were pieces that I just articulated that you would like to see in the budget, please advocate. On the waiver pieces, you know, the number of slots and things, which actually I think is more generous in the House budget by a little bit. You know, that's great, but if it's not funded, that makes it very, very difficult. So that's my lovely budget update. How'd I do?
Yeah, we were very excited to see 2,550 slots placements, which is a whole lot more than we've ever seen in those home and community-based waivers. And it looked like they had both general fund and what they assumed would be the federal part of that. Are you feeling like that's not sufficient to cover those number of people coming in?
You know, it really meets with the overall level of the budget, right? And if there's not enough money for Medicaid, then there's not enough money for Medicaid, and where does that come from? So that's where my concerns come from, Sheila.
Okay. I mean, not okay, but you have concerns.
Yeah.
Do you need some anxiety relief from mental health, or
Yes.
Can I offer that?
Yes, please.
So you talked about a number of things that, and that matches what we heard from the governor's budget people, things that were asked for. I think we were disappointed in behavioral health that AOT, or assisted outpatient treatment, Tibbs law, was not funded. We had hoped that that was going to go statewide. What about the child care funding?
Okay, here's my take on childcare. And I said this in front of committee, so this is no surprise. I think the best use of funds is for universal pre-K. Obviously, I'm a public school person. have been, I used to be over Family Resource Center, so no, that's a place that is in my heart. And so I think that that's probably the best, and I think I've been clear about it. But more money for childcare is good. I think that the House saw the money we put in for childcare, but didn't take account of the 172 that went in for universal pre-K. So, it was a whole package. So you can't just take bits and say you've done it. But I think Senator Carroll's going to have his own proposal coming out. So again, it's as it goes through the process, where are we going to end up? And that's something that I never try to predict with the General Assembly ever.
Yeah, it's very hard to prognosticate with them for sure.
Yeah.
What other kind of legislative related issues are top of mind for you besides the budget? Is there anything percolating over there that
We'll keep an eye on the SNAP bills, keep an eye on there's a bill that I don't necessarily disagree with from Senator Rocky Adams about fictive kin. It's just got a big cost. I think we're going to work with her on what may be possible, but certainly not from a bad place at all. So we'll see. We keep an eye on probably about 20 to 30% of the bills that come through the General Assembly at any time. And those are the ones that we'll keep an eye on.
Yeah, when you mentioned the SNAP bill, just for people that are on House Bill 235, kind of takes the people that are getting a benefit and who are able-bodied ought to be out there swinging a pickaxe or doing something, would require adult participation in a employment and training program in order to get SNAP. And we've seen these proposals around Medicaid in general, but I think that's the one that you're talking about, perhaps.
It is, and honestly, I really like employment and training programs. I think we underdo them here. I would love to see an expansion. It's fine in the 50 cents to match the federal 50 cents to do more. And when I came in, I wanted to see us expand them and maybe work with cooperative extension offices on some of it. We have a decent program, but I always like to think of what more can we do to assist folks. So I like SNAP ENT. I'm not sure mandatory is the right answer, but certainly expansion is not wrong. It's just finding the money to support it.
Oh, yeah, thank you. In the interest of time, I'm going to turn to Dr. Connie White here for a second, because there's a lot of concern about House Bill 141, which is, I guess, being called by the legislature a home rule or local control bill, but it would leave it up to local communities to decide whether to have fluoridation of their water. And we welcome your thoughts about that, Dr. White.
Thank you, Dr. Schuster. Ooh, I'm echoing. Okay. Yes, this is a very important bill for the department and for the cabinet, because as far as the Department for Public Health, we do oversee the water fluoridation supplementation program across the state. We are at the cost of 50 cents per person per year in the state of Kentucky. So that's 50 cents per person to do that fluoridation supplementation. There is fluoride in water, rainwater, ocean water. So this is just getting it to a level, a very low level that helps to prevent 25% of cavities. The CDC has found that fluoridation of the water is one of the 10 top achievements of the century, last century. The other things were things like motor vehicle safety, seatbelts, recognizing tobacco as a hazard, healthier foods, controlling infectious diseases with things like antibiotics, and right up there with that was fluoridation of the water. So we know that we have a problem with oral disease in Kentucky. Our third graders have twice as much cavities as surrounding states, but we do know that statewide fluoridation does decrease the rate of cavities by 25%. So if that protection were removed. That would mean that because of some choices that are made with sugary beverages, going to sleep with a bottle in your mouth, not doing proper oral care, we have a big problem with cavities in Kentucky. In fact, it's the most common communicable chronic disease for children in the state of Kentucky is oral tooth decay. 43% of 4-year-olds in Kentucky have some type of untreated tooth decay right now. You complicate that with counties that don't have a dentist. Without the fluoridation, with the increase of dental disease, you're going to have more oral pain. That's going to affect children going to school. That's going to affect people going to work. People are going to show up in ERs or EDs. Dentists aren't staffed at EDs, so the only thing that they can really do is give you pain medication until you can find dental care. I mean, the circle goes round and round and down into a spiral. The Department for Medicaid Services, and I know there's DMS people on here, but I've got this in my eval, so I'm going to go ahead and talk about it. They're estimating it's going to be about $250 per child when you start having to pay for fixing dental cavities, and around $30 per adult to fix these. Then you add on the emergency department visits, the opioids, the no treatment. So if 68,000 children on Medicaid got one cavity and got it fixed, that would come to $17 million. So putting a supplementation of fluoride in the water, as we've done since the middle of the last century, we know it is helping a problem that we have, which is legion. But it is helpful, and it goes across all socioeconomic barriers because it is in the drinking water and everyone gets access to it. So we're concerned, the Kentucky Dental Association is concerned, the Kentucky Dental Hygienists are concerned, Kentucky Oral Health Coalition, and various water treatment plants and companies around the state are concerned about this. So I'm happy to take questions. Yes, the connection between heart disease, diabetes, there's so much else. And if you have poor oral health, it's difficult to get a job. That you then when your self-esteem goes down, so you've got mental health issues. We like Dr. Schuster has always said, the head is connected to the body when she talks about mental health, and we say the very same thing about oral health. It's very critically tied to chronic disease in Kentucky. So we are certainly hopeful that people on this screen here today will reach out to their legislators and please make sure people understand the breadth and depth of House Bill 141 and the cross the board harm that it can cause. Other than setting my hair on fire, there's not enough words I can say to tell you this is a critically important step if Kentucky takes it to harm developing teeth, children's teeth, and adult teeth, and that will be paid for a lot of those by Medicaid dollars.
Thank you so much. That was really a great summary. I think there is a sign-on letter that's being circulated. Maybe Kelly or Alex can put that link in the chat for anybody that wants to sign on. It joins the groups that Dr. White mentioned, the Dental Association and the hygienists and so forth, but a lot of people that are concerned about kids, that are concerned about overall health, and actually concerned about substance use disorder, because one of the things that drives people to the ER is dental pain. And
Yes.
so they're introduced to an opioid there, and there have been some direct links to addiction following that. So thank you so much, Dr. White. I really appreciate your presentation. And I'm going to turn it over to Tyler Offerman to talk about foodstuffs. Thank you, Tyler.
Dr. Schuster. Yes, so we've covered a lot of ground already. And obviously, as we always say on Thrive, all of this is connected to each other. So the stomach is also a part of the body. And in Kentucky, there's a lot of folks that have empty stomachs, unfortunately. Kentucky has always struggled with persistently high poverty, and that shows up in food insecurity across the Commonwealth. And, you know, this is a problem that has unfortunately only gotten worse since the end of the pandemic. We've seen with the end of a number of pandemic era programs that food insecurity is going up in Kentucky for children, for families, and for seniors. The latest numbers that I found, there are over 150,000 seniors and older Kentuckians that are facing food insecurity. And we consistently rate in the top 5 when it comes to food insecurity amongst those populations. So we wanted to hear from the folks over at the Department for Aging and Independent Living. Marnie Mountjoy is going to share some information with us, what they're up to try and address this. Marnie?
Yes, thank you. Sorry, that pesky unmute button was sticking. Thank you for the opportunity to present and talk to this group. I really appreciate it. Just the fact that we have the numbers that we have for the food insecure in Kentucky is hard. We work very hard at the department to get meals out, and we've been very fortunate through the support of the secretary and the support of the governor and the legislative body that we received an additional $14.4 million this last fiscal year and this current fiscal year to support our senior nutrition program. That's on top of the federal funding that we received. Prior to those dollars, the expanded senior meal program dollars is what we refer to them as, ESMP. Prior to those dollars, we had a pretty significant waiting list for our home delivered meal programs. But through the ARPA funds that we received and the ESMP funds that we've received, we've worked very diligently through our local network to remove everybody from the waiting list. There's still pockets here and there, but that's mostly due to people are turning 60 every day. So we're getting new people on the program, and it's wonderful to get more people on the program, but it's putting more need on our program. In fiscal year 23, we served about 1.2 million extra meals through these ESMP dollars. And right now we're on track to serve 1.5 million meals through these expanded meal program dollars. The governor and the legislators put $10 million in the fiscal budget for each of the next 2 in the biennium budget for the continuation of these meal programs. And we're very thankful. We've been very fortunate that in some regions, we were able to provide those with the greatest need a second meal for the day. We're serving more people than we have before, and not just with a meal, but with information about other programs that are available through our aging network, other programs that are available in the community. So it's more than just a meal. The meal is just the entry point to all the programs and services that we're able to provide. So we will gladly accept any referrals. Anybody that needs a meal, we're committed to getting them a meal, and those individuals can reach out to their senior center. They can reach out to their area development district, or they can contact our department directly. We operate a toll-free phone line known as our Aging Disability Resource Center. We operate that line, and folks can call that number. I'll put it in the chat for everyone to have. Just if they're in need of a meal or any other service, we're open to helping and want to do as much as we can.
Great. Thank you so much for that update, Marnie. And I was also very heartened to see the money included in the budget. As was mentioned earlier, there's a long way to go until that budget is final. So if this is an issue that's important to you, we certainly encourage you to communicate with your legislators. And speaking of which, there was also referenced House Bill 235 earlier, the SNAP bill. That bill in particular would hit folks ages 50 to 59 pretty hard. So, we're very concerned about what legislation like that could do to just exacerbate this persistent problem in Kentucky. But before we move to our next speaker, Marnie, I was told there were some forums coming up that maybe folks be
Yes. Thank you for that reminder. So every 4 years, the Department for Aging, we have the designation as the State Unit on Aging from the Administration for Community Living. And every 4 years, we are required to submit a new state plan on aging. So right now we are in those planning stages and developing our plan. And we're going to be having some community forums next week. So we're going to have 15, one in each of our area development districts. And I will make sure that the information goes out to this group because we'd love to have participation and hear everybody's input. There's also going to be some surveys that are going out. So you don't have to come to a forum to complete a survey. We'll have some information on both of those available. But yes, Tyler, thank you for that reminder.
Great, and we'll make sure folks get those logistics and details. Great, well, next, we'll mosey on over to Todd Trapp from the Division of Family Support Services to talk to us a little bit about the summer EBT program.
Hello, Tyler. Yeah, thanks for letting me be here. I will say, you mentioned pandemic food programs, and certainly one of the biggest ones was the pandemic EBT, otherwise known as PEBT. And we're actually completing our last issuance of that for the past school year. This is just sort of a cleanup for some of the last students that have been determined eligible. So that'll be done on February 15th. And I think in grand total through the years of the pandemic and this last year, pandemic EBT helped over 700,000 unduplicated students in Kentucky. So I think that was pretty amazing. And it was something over $1.3 billion worth of food assistance provided. So we're very happy to have been able to do that, certainly with the support of the Secretary and the Governor. And in that same spirit, we were the first state, I think, in the Southeast region to commit to implementing the new summer EBT program, which will be an ongoing feeding assistance program for school-age kids, any school-age child in a eligible school nutrition lunch program, SNLP approved school, will be eligible for the summer EBT benefit. And so our actual plan for that is due on the 15th of this month. So we're in the process of crossing the final T's and dotting the I's on that and getting that submitted. We'll be implementing this summer. Probably benefit issuance will begin in June. I think that is our preliminary plan. And we think about 270,000 students will be eligible from the direct cert list. And when I say that, there are, to be eligible, you just have to be a student in an eligible school. And there will be two basic groups for that. One are those who are on the direct cert list, which is information the cabinet shares with the Kentucky Department of Education. And it's a match done. Any student receiving SNAP or TANF or Medicaid can be eligible. And that's based on their financial eligibility for those programs. So if a student's on that list and registered in an SLP approved school, then they're going to be eligible for the summer EBT benefit. And as I said, that's going to be about 270,000 students that will not have to apply. One difference from this and PEBT is those other students in those community eligible schools, those CEP schools, will have to apply. And the Kentucky Department of Education, they're estimating for us probably around 30,000 students they think will apply for that during the coming summer. So we're looking at around 300,000 that should be eligible for that benefit. So it's essentially $40 a month for the 3 summer months. So it's $120 benefit for each eligible student. And we will issue that one time per student. So that's sort of the details of that. Again, we don't have our plan approved yet. Once we do, we'll be ready to share, a lot more detailed information and get the word out, get some awareness information out. So
Great. Thank you so much, Todd. And yeah, just to clarify, the PBT program, that was for days missed during school because of the pandemic or pandemic related occurrences, shutdowns. The summer EBT program was just for the summer months. So the PBT program is gone. It will have officially expired with the end of the public health emergency, but the summer EBT program will continue on. And one last thing before I turn it to Dr. White to just give us a quick WIC update is there is another bill, House Bill 367, that would make part of what Todd just said impossible. And that's the direct certification piece. That bill would do away with the state's ability to have some of those flexibilities. And if that bill were to pass, a lot of those kids would lose their ability to get free and reduced lunch. So thank you, Todd, for that update on the program. And we're excited to see the state plan once it comes out. And obviously we'll communicate out to the Thrive family once we have more information. But real quick, before we pass it over, Dr. White, can you talk to us about WIC, Women, Infant, and Children in Kentucky?
Yes, I'm excited to say that I was in Pineville, Kentucky last month, where the very first WIC office in the United States opened 50 years ago in Bell County. So when you hear people say they opened the door to a new process, actually the nurse that opened the door for those first WIC participants was in Bell County. Right now, we have 61 local health departments that have WIC, as well as 2 contracted agencies that provide the WIC program. This is for pregnant, breastfeeding, and parenting persons up to age to the child is age 5, and for that child up to age 5. It is also available for grandparents, and I really want to emphasize that. The grandparents can't get it, but they can get it for their grandchildren. And if you're trying to raise a grandchild on your Social Security, that's almost impossible. This is some supplement that you can help to provide good nutrition for those children. It's a supplement of the foods as well as education to help you understand how that good food can be put to good use and to help those children grow and thrive. Right now we have, as you can see on the slide, it lists the numbers, 101,000 persons, and it's broken down by infants, children, and adults. So just wanted to share this with you. If you know someone who's interested, contact your local health department. We have been hit like everybody else in the healthcare industry with lower staff. So sometimes it takes a bit, but it is available. It is there. It's evidence-based. It improves the nutrition. It helps to lower obesity in children. It is a win-win-win all around. And I appreciate y'all letting me just toot the WIC horn whenever I can, because it is a critical process we have here in Kentucky. Thank you.
Great. Thank you, Dr. White. And then just to end it off, we have a lot of folks that are hungry in Kentucky, and our participation rate across a lot of these programs is really low. So there's a lot of folks that are eligible and are not signing up. So you and other folks across your community can play a critical role in just making sure folks know about this, know that they're eligible, or connecting them with someone else on this call who can help them enroll. So with that being said, I believe I am passing it to Priscilla to talk to us about Medicaid.
Thanks, Tyler. Yes. Hi, everyone. I'm Priscilla Easterling, the Director of Outreach and Enrollment for Kentucky Voices for Health. We have a couple of quick updates. So first, before we move into the other ones, we're going to NEMT, non-emergency medical transportation. So that comment period, there are new regulations that were proposed. Some of those regulations or some of those changes are removing the requirement for a mechanic's note to provide a vehicle or to prove that a vehicle is inoperable, allowing Kentuckians who do not own a vehicle to be eligible for NEMT services, even when there is a vehicle in the household that's owned by someone else. And just generally allowing individuals to access realistic exemptions when needing to use NEMT services to get approved for a medical appointment. We hear from folks all the time about how hard and complicated it is to try and use NEMT. So we're really supportive of these changes. The comment period ended on January 31st. And it was originally on the agenda for today for the Administrative Regulation or Reg Review Subcommittee, but it was removed from today's agenda. And so we're still sort of waiting on that sort of final piece, and hopefully we'll have an update, more of an update for next month. So look out for that next time. So with that, we're going to move on to Kentucky's reentry demonstration. And I am very pleased to have Angela Sparrow here with us from the cabinet, who is going to talk about the waiver with us.
Thank you. Good afternoon. I'm going to try to share the slides. Okay. Can everybody see those okay?
Yes, thank you.
Okay. I'll try to make this brief. Again, Kentucky Medicaid did submit to CMS an application for a reentry section 1115 demonstration that was submitted to them at the end of last year in 2023. It just finished our federal public comment period. I believe again as of yesterday. And so we will be moving into the next phases. And so again, just a brief overview of anyone who's not aware of what a Section 1115 demonstration is. Again, it is an authority and approval from CMS for the Centers for Medicare and Medicaid Services for state Medicaid agencies to be able to pilot and demonstrate new programs, services, innovative approaches to delivering services, et cetera. And so again, many states do operate under a Section 1115 demonstration. There are several different types of demonstrations. The states can apply to add additional components to their existing demonstrations. And so to give you a brief overview of what is the reentry Section 1115, again, it really focuses on promoting coverage and quality of healthcare to improve the care transition from the individual who is incarcerated into the community upon release. Again, the states have an opportunity, state Medicaid authorities have the opportunity to begin providing services and coverage for pre-release services prior to that individual returning into the community. And so this again is the first of its kind. Typically and historically, Medicaid agencies are not able to provide any type of coverage for an individual until they are released into the community. And so briefly, again, an overview of what the demonstration, what Kentucky's request is. It is to cover adults and juveniles, again, and individuals' termination eligibility, again, would not be terminated, but suspended at the time of incarceration so that it can be reinstated. Kentucky requested 60 days pre-release. Again, we are asking to cover case management, a comprehensive case management service to really identify those behavioral health, physical health, and social determinants of health needs of those individuals pre-release, again, to be able to determine and work with their correctional and community partners or managed care organizations to identify pre-release and post-release plan to help facilitate that care, meet those medical, behavioral health, and social needs upon release. We also are asking to cover medication-assisted treatment. This does include therapies and counseling and medications for individuals with substance use disorder 60 days prior to release. And for all individuals, again, 30-day supply of medication at the time that they are released. We are also asking for a recovery resident support service. So this is a service that could be provided by certified recovery residents, again, that meet the criteria to deliver that service. But for those individuals that are returning back into the community that really need that recovery home and environment. We're also asking, again, the services to be approved in our Kentucky state prisons and for our youth development centers. And so again, these are for the youth that are that are adjudicated and are placed in those youth development centers across the state. Again, services can be provided via telehealth or in person. This is very hypothetical timeline. So again, the state did submit. We are waiting feedback and we'll be waiting feedback from CMS to review our proposal. There's usually a negotiation period with CMS following that. They'll have questions for the state and we'll work through that with them. Once the application is approved, that does not mean that the state can actually implement at that point in time. Again, the state will then submit an implementation detailed plan to CMS on how we will roll this out across our correctional facilities. And again, we'll work with our partners, our correctional partners on how to do that. Once the plan is then approved by CMS, then the state may actually implement. But there are many factors, as you can see, that go into that. Readiness assessment for our facilities, budget neutrality, reinvestment plans, and many system changes for our correctional facilities as well as Medicaid to ensure that we're able to have data exchanges to meet the requirements of the waiver. And so again, to help plan and move this forward, as you can tell, this is not only a large change to Medicaid, but our state partners as well, our correctional facilities. That will be again for our community partners also. And so this will be a large initiative. We will be kicking off and planning to develop an advisory board and committee who will oversee and help plan the implementation of the waiver. The advisory committee will be made up of Kentucky State departments as well as our community partners, community providers, individuals with lived experience, and again, certainly our correctional partners and our managed care organizations.
For folks who may not already be connected or have already submitted feedback or anything like that, is there any way for them to get involved with this part, with developing or implementation planning?
So we, again, have reached out through our technical advisory committees and through our advisory, through many of the advocacy groups. So we do have individuals with lived experience and community partners that are going to be a part of the process. Feel free to reach out. We will intend that there will be subcommittees that really kind of branch off as we get going to work in the different areas and components of the waiver to develop that. So certainly individuals, can participate on some of those subcommittees as well. So again, feel free to reach out to us if you're interested in being a part of that. There's an email there, and then again, there's a Medicaid, it's a dms.issues@ky.gov. That is the mailbox that's monitored by the behavioral health team, and you can also reach out to that to get connected as well.
Perfect, thank you. And I know some folks are probably aware that there was a waiver originally submitted in 2020. So what has changed? What changed between what was submitted in 2020 and then what was submitted at the end of December?
Absolutely, yes. Did mention that originally for anyone who's not aware. Kentucky again did request an incarceration amendment to our Section 1115 demonstration in 2020. That demonstration was specific to our adults and for substance use treatment in our correctional facilities. So this request, again, based on guidance that CMS released to states in the spring of last year in 2023, we did amend our ask to CMS to really fit in the guardrails of that directive. And so it is no longer specific to substance use treatment services. Again, that's still a component. In the original request, we did request to cover some of the existing SUD programs in our correctional facilities, and some of those programs can be up to 36 months. And so through the directive and guidance from CMS, again, the states are only permitted to request up to a very maximum of 90 days pre-release. And so again, we are not going to be able to cover those full services while the individual is incarcerated, and really again focus on the what are the identified needs, how can we support that individual and develop that plan for them to reintegrate into the community at time of release. And so again, and we are also requesting coverage for our youth in this amendment, where the original did not. It was just adults.
So there also seems like there's a more developed or more intentional case management piece, and then the reinvestment plan, community reinvestment plan, to make sure that the state's building out supports in the community to help ensure that folks can stay back in their communities when they leave incarceration.
That's correct. Yes, this demonstration opportunity is a little bit different than other demonstration opportunities. And so again, there are additional components to this that the state is required to meet, such as the reinvestment. So again, it's really the state is not permitted to reimburse for, it's not really intended for states to reimburse or provide coverage for services that the correctional facilities would already be providing or expected to provide. So again, if there are those existing services that is already being funded in other manners, again, the state is required and asked to reinvest the match dollars, federal dollars, into the new service or to expand services. So for example, if there's currently only access to the medication for substance use disorder in 6 of our state prisons currently, for example, and we are to expand, required to ensure that that's a covered services in all of the settings that we request in order for the state to be able to expand that to the other facilities and correctional facilities. Again, that could be considered as a reinvestment opportunity.
That's very cool. I'm very excited about the reinvestment piece. Specifically, I think that's a great idea to help just really, again, reinforce that we're trying to help support people as they return to their communities and build out that support there too. So that is wonderful. If there are any questions, please feel free to drop them in the chat. But thank you, Angela, so much for covering this with us. Is there any last thoughts you have about this that you want to share? Otherwise, we'll transition to the next topic.
I think, again, we're all excited. Like you said, it's a great opportunity. This is kind of the first of its kind for states to be able to take advantage of this. And so we absolutely, we've requested, we've been working with our state partners, even through the pending time period that we have. And so we do have great partnerships to build on. Many of the services are, already being provided in some manner. So we do feel like we have a great infrastructure to build on. And so we do want to start where we are, hopefully get a quick approval, and we can build and expand from there.
Fingers crossed for sure. And it sounds like about a 17-month timeline until implementation. So that's a lot of work to get done between now and then. But yes, okay.
It is. It's very tentative. It's a tentative timeline. We never know with CMS.
For sure.
Could be earlier, could be later. So,
yes,
Priscilla,
well,
I wanted just to say this has been such an awesome opportunity to collaborate not only in our cabinet with all of our sister agencies, and then even outside of our cabinet with Office of Drug Control Policy, the Department of Corrections, and Department of Juvenile Justice. Team Kentucky is really coming together to make some very important things for Kentuckians coming to light, right? It's a wonderful opportunity.
Yes, I love that. A wonderful note to end on. Thank you for that. All right, so we're going to transition quickly to Medicaid renewals, and we have Veronica Judy Cecil, Deputy Commissioner Veronica Judy Cecil here joining us. Hello.
Good afternoon.
All right, so it's my favorite topic to talk about.
Mine too.
So what is going on? Give us the overview. What's happening here?
Absolutely. I'm going to share my screen, and we've got some updated numbers to share. I always like to do that. This is maybe a new slide to folks. If you've watched our presentations throughout the unwinding, this looks different. And the reason for that is because in October last year, CMS issued updated reporting guidance for states. We are now required to report once a renewal month has gone 90 days past the renewal month, if there were any pending cases. So this doesn't mean extended cases, just pending cases that were processed in that 90-day period. States are required to update their monthly report that we file with CMS and report the processed pending actions. So this is doing our best to try to reflect that in some way to people who are interested in seeing what that information is. These updated reports are on our website. You'll see the base report, the original report we filed with CMS for that month, and then next to it is the updated report. We have to wait for that 90-day period to close. The report now is for the rest of the remaining months in the unwinding period is due the 15th of the month following the 90-day period. So as you'll see, we're getting ready to file on February 15th. We'll file the report that closed at the end of January for the month of October. If that's not confusing, I don't know what is. So just hang with me here. But so this just, let me walk through what you're seeing here in our CMS monthly report for each of these months from May to September. You see this column that's pending on the left side. Those are the numbers we reported. That by pending, we mean something has been received by the state on that member's renewal. They've responded to a notice. The state hasn't yet processed it. And so it crosses over that renewal end date, and the member remains active while their case is pending. And then at some point, hopefully, the state processes that response. So again, pending column here. In this middle block is the number of cases that were pending cases that were actually processed within that 90-day period following the renewal month. So for example, in May, we reported 2,698 pending cases. We processed in that 90-day period 2,659. And so if you go all the way over here to the far right, you'll see we've now bucketed those approvals or terminations as a result of processing those pending cases. And then you'll see we still have some cases pending, and that is likely due to going back and forth requesting documentation. So, we do try to close those out as soon as we can, but some remain sometimes. So, so you will note, just looking at May again, on the left side, we had 37,182 approvals after that 90-day process pending, processing the pending cases. We have 38,552. And then likewise, we had 34,124 terminations prior to that 90-day processing pending cases. And then we have 35,413 terminations. So those numbers are going to change a little bit based on that, having to file that updated report. And again, those are on our website. So I won't go into these in detail. We'll send the presentation out, but the reports are on our website, so feel free to go out and check those out for the pending. Moving on, as I mentioned, we'll be filing October's updated report on February 15th. So these numbers haven't changed yet based on our CMS monthly report. But we are tracking reinstatements because within that 90-day period is also reinstatement. So somebody was terminated for lack of response, and they reached out after that termination within that 90-day period, and we were able to determine them eligible. We will reinstate them back to their termination date without a gap in coverage. And so we're still tracking those as well. So you will see, we're always happy to see a high number in the reinstatement to see folks are at least coming back in. But the new numbers you all probably haven't seen yet, kind of hot off the press. So for January, we had a little over 121,000 individuals that were subject to renewal. We have so far 67,748 approvals, 10,899 terminations. And you'll see, as you did in October, a large pending or extended population. What extended means is we have several flexibilities out there right now. So if someone doesn't return their renewal, does not respond to a notice within their renewal date, we can give them an automatic 30-day extension to give us additional time to outreach to those folks and try to encourage them to respond. If you're a long-term care or 1915C waiver member, we can give you up to 3 months. So the numbers that are in that extended bucket are just really folks that we're continuing to keep them covered and giving them additional time to respond. So those are the updated numbers. To date, well, let me not say to date. We're still kind of processing. I will say through December, we have 72% of those who have been initiated for a renewal have been approved. So 72% approved. Yes, 28% have been terminated. You know, we're always focused on them and seeing what we can do to try to get them to respond to notice. 50% of our terminations are due to the fact that they've not responded to a notice. It's called a procedural termination. So we're trying to figure out how can we get those folks to respond. But as we've discussed throughout the unwinding, that maybe they have employer-sponsored insurance.
Mm-hmm.
What we do know is on average, about 26% of individuals that have been terminated from Medicaid have other coverage, other commercial coverage. So at least, you know, the number that are being terminated, we can see that some have some other coverage. We also have folks that are moving to a qualified health plan, and I'll show you our qualified health plan enrollment here shortly. I think one thing we're concerned about, just to be candid about it, is the number of people that we see who are eligible for an advanced premium tax credit to help make that qualified health plan affordable, have not elected a qualified health plan. So we are seeing a very small number go from Medicaid and not go and choose that qualified health plan. Of course, they could be already covered under an employer-sponsored insurance plan. And we just can't really see that in the data that we have access to. So we just continue to do outreach to those folks and see what we can do to find out, are they covered? If they're not covered, how can we help them get connected to other coverage? I also want to say, I know one of the questions that I've been asked is, and Priscilla, you sent this to us, which counties have the highest renewal rates? And so what we're seeing is Warren, Kenton, Jefferson, and Fayette. Those two aren't too surprising. They do have the highest response rate and approval rate. And for terminations, what we're seeing is ironically the same, Warren, Jefferson, and Fayette. So in terms of, you know, people we're seeing who have responded terminating. And then some other counties that we're also seeing high numbers in are Davies, Hardin, Oldham, and Boone. So let me jump on over to, oh, go ahead.
No, that's very helpful. I hear from connectors a lot because they're trying to make sure that they're reaching their folks, they're reaching the members of their community and want to do that outreach. So it's really helpful to know like those call outs, like these counties are like very responsive, you know, and maybe some of the other 115 counties that were not named, they need a little bit more help, a little bit more outreach, a little bit more planning. So that's really helpful. Thank you.
You're welcome. So jumping into, we always want to plug qualified health plan because we do hope that people transition to that if they're no longer Medicaid eligible. Although open enrollment closed on January 16th for a qualified health plan, with a qualifying life event, you have 60 days to enroll. So just a reminder to folks who might have a qualifying life event that you can always request enrollment. And for anybody who's Medicaid, they lost their Medicaid, but they want to go choose a qualified health plan because they're no longer eligible for Medicaid. They have now until December 31st, 2024 to go and enroll. They don't have to worry about an open enrollment period. They don't have to worry about a qualifying life event period of time. If you lose your Medicaid anytime throughout this period, you can just go and choose a qualified health plan. And all you have to do is check the box that says, I affirm I've lost Medicaid. And that's what allows that enrollment at any time. So we continue to try to outreach to those folks. We are right now, for anybody that is QHP eligible from the beginning of May 2023 to date, we are calling them, doing another round of outreach when we see they've not either re-enrolled in Medicaid or enrolled in a qualified health plan. We're calling them 2 different times during the day for 2 days, different days during the week. Just trying to find a way to get to them, just to confirm, you know, maybe they're covered, maybe they've got coverage, and that's great if they do, but if they don't, what is it that we can do to help them? So here's the number. What you see, this orangey line that's gone up, that's actually 2024 enrollment, which is much higher than 2023. We were thrilled to see that. Enormous increase, and I think it's a record enrollment for our qualified health plan open enrollment. So that number's great. We continue to track it again just to try to see that we're seeing people get access to coverage. And then just always a plug for communication materials that are out on our website. Please feel free to go out, pull anything down, post it, give it out. We appreciate so much our providers, our advocates, our families and friends that are helping members navigate the unwinding period. So lots of information out there to help members navigate. And then there's our website. Our next stakeholder meeting is Thursday. So if you join us, some of this information may look familiar. But feel free to join us. We always want to have as many people as possible join, but if you can't, it gets recorded and posted on our website. There was a problem to our link, but it should be fixed now if anybody was having trouble with it. You know, follow us on social media.
Perfect. Thank you. I have one last question and then I'm going to turn it over. Big like overview numbers. How many cases have gone through the renewal process and how many are left?
Oh gosh, you're challenging me. Hold on.
Putting you on the spot.
I know. Well, so if I add up, although I don't have the pending number, I mean, we have over 455,000 people, over 455,000 people who have been approved. We have around a little over 179,000 who have been terminated. We are about 65%, now with January closing, about 67% through all of our renewals. So, you know, maybe even actually a little higher than that, maybe quite closer to 70 now. And the good news is our, you know, child renewals, that still is going on where we're automatically, so if we had children in any of these months, we're automatically renewing them for 12 months. They don't have to go through a renewal. And so that will continue. I think the question becomes, so our flexibilities are still in place. And, you know, CMS issued something that allows them to go through December 31st. They're meeting with each state just to go through all the flexibilities and make sure everyone understands what that means, as it applies to our renewals. So, we have not had that meeting with CMS yet, but, they are interested and are asking states just to report the last cohort of first renewals. So, you know, when we started this back in with May renewals, we had how many people that we had to do a renewal for. And so now they're just sort of checking back in with states to see when will you complete your last round of first renewals, because we're gonna in May, we're gonna start now with second renewals for people. So again, you know, we're just sort of monitoring that and seeing what we can do to continue to help folks going through the renewal process.
Awesome. Thank you so much for joining us. If, again, as you mentioned, there's the monthly stakeholder meeting. So if anyone has more questions, wants more information, definitely check those out. They do a full hour deep dive. So thank you for joining us today. And I'm going to quickly hand it over to Dr. Schuster.
Thank you, Priscilla. And we're about at the end of our time. I'm going to ask Leslie very quickly, because there's been so much talk about the mobile crisis. Leslie, and my concern is that we know that the contract has been signed with Carillon as the administrative services organization for the new program. But as the secretary said to us, the funding that was in the budget for mobile crisis is not in there, at least as the budget passed the House. So I know that you had some slides that you were going to present on mobile crisis generally, but I wonder if you could focus on that question.
I think my answer is going to be the same. I'll have to defer to the secretary as far as the budget not being finalized yet.
All right. Do you want to post your slides, or can you?
Is it okay? And everybody already knows me. I talk very fast anyway. So, and I'll share this with you later, Dr. Schuster, and you can.
Yeah, we'd like to be able to.
But I can go over this
people.
fairly quickly. Just a second. Make sure I've got the right screen. Okay, can you see my PowerPoint now?
No, yeah. Well, we
You
see that your screen there. There we are. Yeah.
You see it? Okay.
Yes.
And I'm just going to keep it in this mode, and I'll run through this fairly quickly. I based my PowerPoint today basically on what you were asking in the agenda, what was the goals and how are we going to help Kentuckians and what was the timeline. So that's kind of where I based this. I gave you a little bit of background for those of you that might not know a whole lot about this initiative to begin with. So first of all, our goals seemed very simple to get started. We wanted to develop a one all-inclusive Kentucky mobile crisis continuum. We wanted to ensure behavioral health crisis services for any Kentucky resident, anywhere, anytime, and with no wrong door. We wanted to assess Kentucky's needs for behavioral health crisis care, and we wanted to evaluate the current crisis service delivery landscape. Also, we wanted to follow SAMHSA's national best practice guidelines for behavioral health crisis care, which includes someone to call, someone to respond, and somewhere to go. So next of all, we had to figure out, like, how are we going to get there, right? How do we figure out what Kentucky really needs and what members need and what folks that are working day to day, boots on the ground, are going to need? So we applied for a grant, and I'm just going through this very quickly, but you totally can reach out to me. We did a huge comprehensive stakeholder engagement, strategic planning. We collaborated with sister agencies and communities, advocacy groups, first responders, anybody. We did 3 months, boots on the ground, talking to everybody we could. What works, what doesn't work, what works for a first responder in Taylor County might not work for a police department in Fayette. Those were the kinds of things we were trying to figure out. And I won't go into this, but there's a 258-page needs assessment that we completed over that 3-month period of time. Somewhere around page 10, if you don't want to read the whole thing, somewhere around page 10, you can read a 20-page executive summary, which will give you a really good idea of what that 258 pages has in it. So some things that we identified right off the bat is that we had to figure out what was going on as a current state here in Kentucky. We had all kinds of wonderful programs that we could leverage that were going on, but a lot of them were limited funds, limited access, workforce development kind of problems, and those kinds of things. So we had to do a kind of just look at the landscape. We identified some unmet needs in the community. We identified unmet needs in the service delivery continuum. And so we established the need for policy, design, and communication. And this goes right along with what we identified. We established the need to enhance core elements of Kentucky's mobile crisis delivery. We established the need to address the challenges in rural communities and with at-risk populations. And you'll hear me talk about that a lot. I wanted to ensure that folks were responded appropriately with the type of behavioral health crisis they were in. So you've heard me mention this, a 25-year-old person in the LGBTQ community might not be having the same crisis scenario as an elderly person with anxiety and depression. So I wanted to make sure that it's appropriate for the member. We made lots of recommendations aimed to improve access to crisis care, the service delivery, and the provider capacity. So oftentimes people ask me, was this just a project management change, just change what we have? And it was not. This is a change management approach where Kentucky took a deep look within ourselves to see what we were delivering and what we had and what we could leverage, all those good programs that I told you about, and to incorporate or leverage those into what we were going to develop. So it was an evaluation of our current crisis service environment to assist CHFS with the development of a meaningful mobile crisis continuum, again, for all Kentucky residents. So again, when we started work, then this brought on more goals. It's when you are learning, it brings on more things to learn about. You all have been in that situation, I am sure. So closing the gaps and helping all Kentuckians. We wanted to aim to close the gaps in behavioral health crisis care for all Kentuckians. So again, we had new goals that kind of started to come about. We wanted to reduce inappropriate emergency room department utilization and incarceration rates for individuals that were in a behavioral health crisis. We wanted to increase utilization of appropriate levels of care for individuals experiencing the behavioral health crisis. We wanted to increase provider capacity and member access to crisis intervention services and referrals. And then goal 4 was to leverage the dollars, not only from those wonderful programs I told you about that we want to leverage here in Kentucky, but what we're spending in inappropriate placements to enhance the service delivery and to provide better outcomes and a better quality of life for the members experiencing a behavioral health crisis. And I know that's a lot of redundancy when I'm going through this, but these are things that we really wanted to see happen here in Kentucky. So from the needs assessment, we found out 2 things. We were going to need more than just what CMS was offering in an opportunity letter. So we call that the Commonwealth model. And the Commonwealth model is all those things that CMS gave in their state health organization letter and opportunities for mobile crisis. And I've got those things listed if you wanted to pursue extra enhanced funding for your state, which was a wonderful opportunity. And it was going to give us 12 quarters of enhanced funding. But we also realized for Kentucky, we were going to need a lot more. Although we want to minimize law enforcement involvement, especially in unnecessary law enforcement involvement, we know in rural Kentucky, where 112 of 120 counties are deemed rural federally. we knew we were going to need more. We were going to have to help in those rural areas that I told you about. And we were also going to have to leverage every program we could to build capacity for our Kentuckians. So we developed the community co-response model. I've never been involved with such an opportunity as this. This administration gave us an opportunity to support a notice of funding opportunity grant for municipalities that might want to apply for a grant that would help them to assist, say, to expand or enhance or to add a social worker to their team when they go out on calls. So this was a very humbling experience, if you've heard me say that before. And I wanted to share with you because I'm so very proud of them. These are the first recipients of the Community Co-Response Grant here in Kentucky. And as you will see, it's a variety of folks across Kentucky: Boyle County Fiscal Court, Christian County Fiscal Court, Cynthiana Police Department, Lexington, Fayette Urban County Government, Maysville Police Department, Perry County Ambulance Authority, and the Warren County Sheriff's Office. And we will work hand in hand with them with their grant, providing training and technical assistance. And so this was, I say this all the time, it's just a really humbling experience to see a Boyle County or a Christian County team just wanting to help their local neighbor, wanting to help the folks that they know are in the local community to be successful and have help during a crisis situation. So I just wanted to mention that. So this is a just a visual for you, but it talks about what SAMHSA wants, and that's someone to call, someone to respond, and someone to go. We felt somewhere to go. We felt like we met these three items, and so we kind of feel like we meet this goal. And this is our grid here, and I've got all kinds of wonderful visual opportunities, but this one kind of pulls everything together. Our administrative service organization for oversight, quality, and equitable mobile crisis service delivery will have those folks, as well as our Commonwealth model and our, let me just take that down just a tad, and our community co-response model. And so all of those working together, will have a person in crisis. They'll either come through 911 or 988, and they'll have access via phone, chat, or text 24/7, 365. And big shout out to the 988 call centers that are currently here in Kentucky at our CMHCs and under the Department of Behavioral Health. We are leveraging the great work that they are doing to move this forward. Someone to call, it could either come through a call crisis center or through 911. Someone to respond would be a mobile crisis team through that Commonwealth model, or it could be one of our Commonwealth co-response units. A place to go, next level of care. We had to develop based on that needs assessment. We developed multiple options for transportation. We developed a united mobile crisis service definition in a state plan amendment that was approved. And we developed a 23-hour crisis and stable observation and a stabilization unit so that folks would have a place to go. Our co-response models are able to use the place to go. So if a police department has someone and they don't have a place to go, they can go to one of those facilities, and CMS has already approved that in our state plan amendments. And then resolution is really about our post-crisis support and care and connecting that person and doing longevity and follow-up with that member who has been in crisis. Oh, I'm sorry. I'm so sorry. Our technology for this piece is very interesting because we can utilize help to, while folks are in transit, we can keep them. For example, Dr. Schuster, Dr. Schuster gets calls into 988. They do a triage dispatch and realize that Dr. Schuster will need our assistance. They stay on the phone with her through this technology and never let it go. So say if Sally was on the phone with Dr. Schuster, she will stay on the line with Dr. Schuster until Leslie comes online and says, I've got you, Dr. Schuster, and I'm on my way. I'm on my way to help. Okay. So there's never, that was one thing we wanted to make sure. We wanted to make sure we had the technology to never let anybody go. We can also do things like track referrals, and we can do bed registries through this, and just lots of other quality things to provide out there. So with that said, we did feel like we in 2024 met our goal to develop a unified mobile crisis strategy. And really, this is just the things I told you about. It included 4 more goals. So as we kept rolling this out, we realized that we would have more goals along the way. So the administrative service organization, you did ask me about that. So just real quick, our administrative service organization, we contracted with Carillon Behavioral Health, formerly known as Beacon Options. And our expected service go live date is July 1 of 2024. So you say, what are you doing now? There's lots of work to get prepared for June. I will tell you that. We've had lots of introductions, collaborations, meetings, contracts, and we've already met with our MCOs. We met them jointly, and then we're meeting with them separately. We've met with our CMHCs, our community mental health centers individually, jointly, and then individually, and with our certified community behavioral health clinics. We will be meeting with our BHSOs, behavioral health service organizations, and then we will be moving on to our other interested providers that can meet the criteria to be able to provide these services and contract with our ASO. And that is a lot said in a very short period of time, Dr. Schuster. You're always welcome to reach out to me, but we do have a designated email box, KentuckyMobileCrisis@ky.gov.
Thank you. And you're going to share those slides so we can send those
Absolutely.
out. Thank you. I guess I will circle back with the secretary because when you look at that timeline to pull all this together by June 1st seems, you know, unbelievably fast. And I worry about the funding that was not in the budget, and maybe it'll get back in there on the Senate side, but we appreciate that, Leslie. Thank you.
You're welcome.
And I appreciate everyone who has stayed on for an additional 15 minutes. We did have on the agenda the 1915 state plan amendment. We have sent out a ton of information to everybody who's interested in that. And we're going to be following up with some informational meetings and discussion. Pam, I would just ask you if you had prepared any additional slides, if you would mind sharing those with us so we could send them out to people. And I don't know that you did.
I do. I have some, and actually I will share those because there's a link in it on directing us specifically where to go to find the waiver that's posted for public comment in the summary. And just to encourage people to comment, we've received very, very few comments, like less than 5 as of right now, public comments. We're trying to share reminders. We've been sharing them on social media. We've got a cadence of reminders that are going to go out to kind of the distribution list and the email list. So I will send this on so that it has those links in there as well. So that
Yeah, that would be very helpful. I think part of the thing is that this is it's complicated, as you know.
Mm-hmm.
And what I did when I sent out the information is, you know, Kelly and Val and some other people that are on here, you know, we sent out every link that you all had sent out originally. And it's really helpful to have the summary that you all did. I would direct people to that in particular, but also the frequently asked questions I think are extremely helpful.
Mm-hmm.
And the public comment period ends at midnight on February 28th. So we still have some time.
Yeah, we've got some time.
Yeah, and we are sending it out. I know all the NAMI affiliates and NAMI Kentucky are working with us, Marcy Timmerman at Mental Health America. And as I say, we're going to have an informational meeting with all of those groups tomorrow afternoon. So I'm trying to distill it down even further because I want people to be able to, and actually Kentucky Voices for Health is helping us out by doing their comment collector, which they are famous for. They really get that out there with some good parameters. So we're going to get you some comments. Trust me, they're working very hard on it, and I do appreciate it. And if you would send your slides along,
I will send that.
That would be very helpful. And I'm going to wrap up here. I again appreciate all of you, and so many of you have stayed on even much longer makes me wonder if sometimes we need to have 2 hours for this. And appreciate all of our partners at the cabinet for being on and sharing their information. We will follow up. You know, we're very good at sending out everything tomorrow or at the latest the next day. So you'll get all of the information that we've discussed, and as well as the dates for our roadshow. We're doing the roadshow again. We're not going to 15 cities. We're going to 7, I guess, or 8. So you'll get all of those links and dates also. So I'm going to bid you all a fond farewell, and thank you so much for your advocacy and your interest. And thanks to our companies that are supporting our ability to do this work. Thanks again to our partners at the cabinet, and have a good rest of the day. Bye-bye.